Hello and good evening, all of you.
Hello.
It's an honor and it's a privilege to welcome all of you for the 15th episode of Virtual Bariatric University. I hope all of you can hear me clearly.
Yes.
Okay, so good afternoon, good evening, good morning from whichever part of the world you are. I think this webinar is going live to almost uh, all different IFSO host countries and many surgeons across the world. For the episode 15, we have a very interesting topic. In fact, we received a lot of requests that we host this topic with such honored faculty members, that is management of non-responders after one anastomosis or a mini gastric bypass operation. So welcome all of you. I would uh, take this opportunity to introduce the faculty members. First, we have Professor Robert Rutledge from USA. Uh, Professor Rutledge had 20 years of its stint at North Carolina as an associate chief of staff, professor of surgery in trauma, critical care, and bariatric surgery. And at that time, he developed this procedure by serendipity called as mini gastric bypass when he was trying to treat a gunshot wound. Professor Rutledge has published a lot on mini gastric bypass because he was the innovator. And Dr. Rutledge applies the same technique of cholecystoplasty and Billrod-2 gastrojejunostomy, which is the mini gastric bypass. Dr. Rutledge has been honored as a visiting professor to different countries, teaching his surgery and moving around and training surgeons. So, welcome, Professor Rutledge, to this particular course. And uh, I would admit that in 2010 and 11, Professor Rutledge was instrumental to help me start mini gastric bypass at Indore at our center. So, welcome. We have next Professor Mario Musella from Italy. Mario is a great friend, and to introduce him, he is a professor, a full-time professor of surgery at Federico University and Advanced Biomedical Science Department in Naples and Italy. Professor Musella is a past president of MGB OAGB Club, and he hosted a beautiful meeting in Naples where myself and Professor Fobi were there, and we enjoyed his hospitality. He has also served as a university researcher and a staff surgeon in Department of Experimental and Clinical Medicine, General Surgery at the Magna Graecia University in Italy. He has published several papers, book chapters, edited and reviewed many for many academic journals, and I think he's one of the most respected members in the MGB group. So welcome, Professor Musella. We look forward to interact with you. Next, we have Dr. Liza Maria Pompa. Dr. Pompa is from Mexico, and she is a bariatric and metabolic surgeon who is a director of a center of excellence in Tijuana in Mexico, is a member of scientific committee of Mexican College of Bariatric and Metabolic Surgery, and is also the vice president of the American College of Surgeons, uh, the Nor-Occidental chapter. So welcome, Dr. Pompa, and we look forward to listen to you and to have your views. We have Dr. Amir from Iran, and Amir is a consultant minimal invasive and bariatric surgeon and also assistant professor in general surgery at Shariati Hospital. He is on the editorial board of both JRMS and ABS, a reviewer in obesity surgery, and has multiple publications in bariatric metabolic surgery. So welcome, Dr. Amir Jazi, to this meeting. I'm pleased to introduce my friend next, Dr. Jammu from India. Jammu is the director and the founder of the state-of-the-art Jammu Hospital, which he started in 2000 in Jalandhar. And it's one of the most reputed hospitals for bariatric and metabolic surgery, not only in India, but he has a lot of international patients, and he is famous in most other parts of the world to operate this procedure, mini gastric bypass. He is also a founder member of MGB OAGB Club, is an international faculty in most bariatric metabolic surgery conferences, and has, I would say, has pioneered one of the largest volumes of mini gastric bypasses along with Professor Kular here in India. So welcome, Jammu, to this meeting. And Gurvinder is also a great friend and a great human being too. Next, Another good friend, Dr. Atul Peters. He is the Director of Department of Bariatric and Minimal Access Surgery at Max Super Speciality Hospital in Saket at New Delhi. Operates in India, Dubai, Muscat, and several international destinations. His particular area of interest is laparoscopic, robotic, and bariatric surgery and GI surgery, board certified by the National Board of Surgery, and has several other fellowships to his name. He is a founder member of ACMOMS and holds a world record for performing the highest number of bariatric surgeries in a day, and also declared in the Limca Book of World Records. Welcome, Dr. Atul, to this meeting. And we know that you have a great sense of humor, and we look forward to listen to you and to your jibs all throughout the meeting. Last but not the least, I have Manoj Kumar Reddy. Manoj is a consultant surgeon at Mohit Bariatric and Robotics here in Indore. He completed his general surgery at Narayana Medical College in his residency at Narayana Medical College in Nellore, and then he did a fellowship with us. But now he is one of the supporting structures of Mohawk Bariatrics and Robotics, one of the persons we can lean upon and trust and have confidence to assist us in running this department in a fantastic way. So Manoj, welcome, and he has a good presentation today, and I myself personally look forward to listen to it. I have with me my teacher, my mentor, Professor Fobi, who co-directs the virtual bariatric university with me. And without further delay, let me now invite the first group of panelists, Dr. Mario, Dr. Gurvinder, and Liza Pompa, to moderate the lecture sessions. Over to you, Mario.
Thank you. I think. Dr. Pompa, you're first.
Yes.
So it is an honor to be with you this morning here in Mexico, this evening over there in Indore, India. So I would like to also give the word to my co-hosts so they can present themselves. We will be presenting the speakers.
Dr. Jammu.
Dr. Jammu, you have to unmute yourself. Unmute yourself and then start to speak.
Am I audible?
Yes. Go ahead.
First of all, thank you, Dr. Mohit, Dr. Fobi, for giving us this common platform and opportunity to discuss about the shortcomings of mini-gastric bypass. And this is going to be a very interesting and challenging talk and discussion today. So looking forward, learning something new and sharing new things with each other. So thank you for the invitation.
Mario.
Good morning or good afternoon from Italy to everybody. It's a pleasure to be here. Thank you for your invite, Dr. Fobi and Dr. Bhandari. Well, these are difficult times for every one of us. We have been stopped from traveling and meeting each other, but thanks to these webinars, it is a partial reward that allow us to meet all over the world. So happy to be here and eager to listen to the presentation that is coming.
Jammu, start.
Yeah, so not taking much time. We all, Mohit has already introduced all of us. So I think we will come straight to the presentation by Dr. Manoj Reddy. So he has a case to show the cases of weight regain and some GERD problem after mini-gastric bypass. So what is the procedure done and what are the after results? So we would like to know from Dr. Manoj Reddy the case and then subsequent discussion on that part.
Hi everyone. Today I'll be presenting the case report of a weight regain post-sleeve conversion to MGB and what we did later on. Yeah, it is a case report of revision of OAGB for weight regain and GERD due to hiatus hernia. This is what I'm going to present, a case report of revision of OAGB for weight regain uh, due to hiatus hernia and GERD. And I bring greetings from the place I work, Mohawk Bariatrics and Robotics, and Sames campus Indore. There are no disclosures for me. And Dr. Fobi is a founding president of Bariatric Corporation, whereas Dr. Mohit Bhandari is consultant to Johnson & Johnson, Medtronic, Bariatric Solutions, Intuitive Surgical, Carlstor, Stryker, Apollo Endosurgery, Pentax, and Olympus. This is our case mix disclosure. We do all kind of cases, including sleeve gastrectomies, gastric bypass, OAGB, ESG, balloons, and even we ban certain procedures. And coming to case, he's a 54-year-old male with the complaints of MOOSA, type 2 diabetes mellitus, hypertension, osteoarthritis, and coronary artery disease. He underwent PTCA 3 years back. And first surgery he underwent was lap sleeve gastrectomy, which was done in April 2012. His weight was around 130 kgs with a BMI of 50.78. He lost 45 kgs in a year, 9 months to 12 months. And his lowest weight achieved was 85. And then he gradually started regaining weight. And he presented to us in October 2014 with a weight of 111 and a BMI of 43.35. So, revision was planned from sleeve to mini-gastric bypass with a limb length of 250 centimeters. And then he again presented to us in 2018 with a weight of 101 and BMI of 39.4. This is after undergoing MGB with his present complaints of hiccups since 2 months, heaviness in chest, and occasional bilious vomitings since last 2 weeks, and a weight regain. And as we went in with endoscopy, this is the graph showing his first surgery when he underwent sleeve gastrectomy. His weight was 130, and then lowest after sleeve gastrectomy was 85 kgs. Then he gained weight in almost 18 months from 85 to 111, that is 26 kgs. Then he underwent OAGB, MGB. Then the lowest achieved was 90 kgs. He lost 21 kgs, but he never crossed his previous weight of 85 kgs after this surgery. And then he gained 11 kgs after that, and he had the complaints of vomitings with hiccups and heaviness in chest, where we took him for endoscopy. And these are his blood reports, which shows albumin of 4.1 and HbA1c of 6. A patient previously had a type 2 diabetes mellitus. He's on remission post MGB, which is very good. In fact, and HB of 12.7 and no major abnormalities, and USG showing fatty hepatomegaly. This is the video I want to show you. This is the endoscopy. You can see LAB esophagitis. That is GE junction. Yeah, and we can see bile with food particles over there. And this is the diaphragmatic constriction, which clearly shows a hiatus hernia, which is why patient is having those complaints of vomiting, heaviness in the chest. Both afferent and different limbs can be seen clearly here. No marginal ulcer whatsoever. Whatever we can see is a little bit of gastritis or pouchitis. And as we've seen here, as hiatus hernia is confirmed, we went in through laparoscopically, and we started dissection from pars flaccida, continuing through to the esophagus. Crus is being mobilized, and the lateral adhesions are being removed. There is no remnant in this case, minded, because he underwent sleeve gastrectomy before, which was later then converted to MGB. So just the lateral adhesions are being removed to the pouch, so that we can mobilize the crus, left crus laterally. The adhesions are being taken out with harmonic shears. Dissection is being performed at the GE junction. As you can see, the esophagus is being manipulated in. This is the entire hiatus hernia, which is pulled back. Now with both crus can be seen clearly visible, all adhesions taken off. G junction is clearly visible over there. Now endo stitch with loaded with non-observable surgical suture is being used to take the sutures to fix the crust. All this is being done with bougie in, so that we may not make it too tight. And then now we continue with making the pouch for the gastric bypass. The bougie is being called in so that we can make a tight pouch, and the excess dilated MGB pouch is being dissected, which is, and then band is being applied now, which is a handmade ring, handmade silicone ring. The gastrotomy is being performed. Now this is the previous gastrojejunostomy of MGB, which will be dismantled. To do it, the adhesions are being removed, adhesiolysis is being done. This is where we get a stapler, and then the GJ is dismantled. This remaining pouch will be taken out as a specimen. And this is it. Now we'll count the BP limb which we took during MGB, that is 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, 180, 190, 200, 210, 220, 230, 240. As you can see, it's like 240 to 250 centimeters. Even after 250 centimeters of bypass, patient had a weight regain of almost 21 kgs post OAGB. So now this 250 centimeters will become our BP limb for the gastric bypass, banded gastric bypass. Scoring of mesentery is done. Now the rule limb is being counted for, which is around 90 centimeters. Jejunostomy is being performed. The closure of jejunostomy with the suture material is being done. Now jejunal mesenteric space will be closed, which if left open can result in a internal hernia, which has a chance of 2 to 15% in a literature. This is done with a non-absorbable suture material. As thin bites are being taken so as to cause adhesions, so as to prevent hernia. Now we take rule limb up for gastrojejunostomy. We have already created gastrostomy. The gastrojejunostomy is being closed with absorbable suture material. The band will be fixed. Patterson place is being closed now. Even here we take very thin bites so as to cause adhesions over there to prevent a future hernia. As you can see the bowel over there, which might come in as a hernia later on. To prevent that from happening, we take these, we close the Peterson space. That's it. Now the band will be fixed with the same non-absorbable suture material. And post-op patient was doing well with no symptoms of hiccups or vomitings whatsoever. And he was on liquid diet and he was discharged on third post-op day. And this is the follow-up from the 101 kgs. At 101 kgs, we did banded gastric bypass. His weight achieved now is 76 kgs. And he's doing fine under no symptoms regarding vomitings or anything else. Thank you. This is the team which we work with at Mohawk.
Well, are we
Go
ready?
ahead.
Are we ready
Yes.
for the discussion?
Yes.
So, Dr. Reddy,
Yes.
basically you did both the things. You again added a restriction, element of a restriction,
Yes, we added a little bit
element
of
of malabsorption. You increase the both.
yes.
So what, according to you, do you think is the long-term effective? Is it the restriction again or the malabsorption? So what do you think?
Both of them will work now. I think so because even with the 250 limb bypass, he used to eat a lot. So maybe he gained it. So we added a restriction to that with banded gastric bypass.
Dr. Rutledge, I would like to have your views.
Looks very, it looks very good. I congratulate you on great surgical technique. And of course, you have picked a patient with good success, and I honor you and respect you. What I would recommend as an interesting idea to my brothers and sisters is Facebook.
Yes.
Here's my experience. In the past year, since I've been in the pandemic, I have been talking to MGB patients, but also to failed sleeves and failed Roux-en-Y's. And so if you have a pencil, you could write down this Facebook page. It's called Weight Loss Surgery Ruined My Life. And that is a very sad, tragic group of individuals who are suffering some truly terrible complications, malnutrition, loss of teeth, being fed through a feeding tube and things like that. So I'm very complimentary of the excellent results. I would say that if you go out and look onto these kind of public sites, it can be very eye-opening to see the complications that can occur with some of our bariatric procedures. But again, my compliments for excellent result.
Thank you, sir.
Okay. All right, we'll go on to Dr. Pompa, please. Unmute yourself.
Yes, I am pleased to invite Dr. Amir to make his presentation. The talk would be on revisional surgery after one anastomosis mini-gastric bypass, a narrative review.
Hi, everybody. Thank you for inviting me to this prestigious webinar. Can you see my slides?
Yes.
Yes.
Okay. I want to talk about revisional operation after one anastomosis gastric bypass. This is a published narrative review 1.5 years before. Last week, Professor Fobi talks about definition of non-responder. A non-responder is not equal to patient that have some weight regain. Other complication that led to reoperation may be considered as non-responder. So let me go ahead. I'm from Isfahan, Iran. You can see the picture of Isfahan, a historical city at the center of Iran. I have no conflict of interest, and you can see here my case mixed disclosure within recent 5 years, more than 800 of operation by this fashion. This is the first page of published paper in JRMS. I want to explain about potential advantages of OAGB. Everyone knows that it is technically easy. The operative time maybe some shorter, and there is low complication rates, simpler revision and reversal, and lower incidence of internal hernia in comparison with row-and-wide gastric bypass. In the literature review, we can find 4 main causes of revisional operation. These 4 causes are categorized in this slide: malnutrition, reflux, marginal ulcer, and inadequate weight loss. When we performed this project, we collected more than 17,000 of published cases. And we found that 83 marginal ulcer, more than 200 of reflux, and 150 of malnutrition, and 20 cases of weight regain. For marginal ulcer, the first complication, everybody knows that there is some prevention. We can do something to prevent marginal ulcer. For example, long, narrow patch. I don't know that how narrow is good and how narrow is bad. The width of the patch should be defined again. Anyway, use of absorbable suture, or performing retrogastric gastrogenostomy, or continuing PPI for at least 6 months or maybe later, and smoke cessation and learning curve more than 50 cases may reduce the risk of marginal ulcer. So this is for prevention. But in some cases, we have diagnosis of marginal ulcer. If the marginal ulcer persists, we should start medical therapy by PPI and antibiotics, because you know that many of these marginal ulcer is related to Helicobacter pylori. And if exists at the follow-up, and if is refractory, we should take into account conversion. Conversion to row-and-wide gastric bypass is the main reported revisional operation for marginal ulcer. Other authors introduced sleeve gastrectomy, Brown jejunectomy, anastomosis, revision, vagotomy, or complete reversal. But if there is perforated marginal ulcer, laparoscopic or laparotomy with omental patch and drainage may be indicated. The second complication is reflux. You know that acid or bile reflux are different entities and with different pathophysiology. Some papers introduced anti-reflux mechanism of OAGB. For example, the weight of large jejunal loop maybe increase the length of intra-abdominal esophagus, and it can cause more pressure in LES. And also dependent gastrojejunectomy may be indicated as anti-reflux mechanism. About Carbajo suture, I know that some authors and some surgeons do these sutures, but this is not global consensus for this suture, and no evidence-based benefit reported by the others. And some other authors are reported that pre-existing reflux may be treated by OAGB. For example, Professor Rutledge reported 77% or 85% resolution of reflux, pre-existing reflux after OAGB, or Carbajo mentioned 100% improvement. You know that reflux have some risk factors. For example, preoperative GERD or revisional OAGB or short patch shorter than 9 centimeter may be risk factor of reflux after OAGB. There is some discrepancies between symptoms, endoscopy, and histology. You may have a patient with symptom of reflux, but in endoscopy, you didn't find any pouchitis, gastritis, or in histology, there is no evidence of inflammation. About medical therapy and duration and drugs, there is no consensus or agreement, global agreement. Many surgeons start PPI and bile binder for treatment, and after 3 or 6 months, if the symptom are exist, they should convert the operation, like case that we see here a couple of minutes before. You know that there is difference between de novo GERD and pre-existing GERD with different pathophysiology. Anyway, when you have reflux and the patient have refractory reflux, you should convert to Roux-en-Y gastric bypass with or without patch resizing. For example, if the cause of reflux is short gastric patch, there is no need to patch resizing. But if the patch is too long and there is also reflux, maybe patch resizing should be considered. If the patient, rather than reflux, have excessive weight loss, we should do something for excess weight loss, for example, lengthening the common channel or conversion to sleeve gastrectomy or total reversal to normal anatomy. Anyway, some authors proposed brown jejunostomy, but there is no agreement that it may be that it does not work enough for reflux. The third complication is malnutrition. Here you can see different enormous surgeon pioneers of OAGB. You can see the numbers of malnutrition reported here with different treatment approach. Some authors did not perform any surgery for malnutrition, and some others revised by the operation to normal anatomy, to sleep, or something like that. Some authors also suggested to reduce malnutrition, we can reduce the length of BP limb, 1.5 meter, 2 meter is enough. And the fourth complication is weight regain or inadequate weight loss. You know that there is more than 30 definition of weight regain and inadequate weight loss. Less than 50%, less than 25%, excess weight loss or total weight loss or excess BMI loss. Every definition were used in different reported paper. Anyway, Professor Lee and dear Mario reported 20 cases of weight regain, that some of them underwent DS or BPD, and some others performed by Professor Musella by distalization or patch resizing for weight regain. Anyway, I want to tell some take-home message that there is 4 common causes for the operation: marginal ulcer, reflux, malnutrition, and weight loss failure. And surgical intervention should be taken into account at the earliest stage. Mainly Roux-en-Y gastric bypass or total reversal should be indicated in relevant cases. I want to thank you all, and I'm in your service for any question. And also I want to special thank to the co-author, Muhammad Kermansaravi, from my friend, and another Professor Mahobar, the co-authors of this paper. Thank you all. I'm in your service if any question.
Thank you for this great talk. It is very interesting to see the diverse complications that are reported in the paper. So I will ask your personal opinion on which complication do you think it's the most, has the most repercussion in a patient, in your experience?
You know that I look like a young surgeon, and young surgeons have no enough experience, but in my own practice, I see many patients with malnutrition and depression and guilty sensation to perform this operation. I think this is the most devastating and catastrophic situation. You know, the patient with reflux come to your office and say, I have reflux, I'm vomiting, and you go for surgery or for drugs. But patient with malnutrition maybe forget himself or herself, and maybe his father, her mother, come to your office that my son or my girl is depressed, no food, no attention, no supplementation.
I understand. Thank you for your comment.
Dr. Amir, because primarily because what we are discussing is weight regain after an MGB, right? So have you had any chances wherein the patient came to you after an MGB with a weight regain? If yes, what is your algorithm to go about treating such patients?
Okay, in my experience, it's very a small experience. I showed you 800 operation. I didn't have any patient for after my own operation after OAGB. My concern is underweight. My concern is excess weight loss rather than this. But I didn't have any patient for this. But I read at the paper that performing distalization, you should at first see the anatomy. If the patch is too large, if the fundus is remaining, if something like that. And at first line, you should perform psychiatry, nutritionist. At first, there is some patient that drink more and more and more after operation, and this drink maybe cause excess weight loss, and every operation maybe fail. For at the first time, at the first step, I will send the patient for consultation with psychiatric and psychology like that.
Dr. Musella?
Sorry, please go ahead.
Yes, thank you, Lisa. Well, I will make a very quick comment. In my experience, I'm going to show you just in a few seconds some slides that comes from a nationwide survey we made in Italy about all patients who had to be revised following a problematic OAGB or MGB. And we found that less than 2% of patients had to be converted. Well, sometimes I faced some malnutrition, but it is very rare in my experience. I remember of a couple of patients I had to revise, just two of them. And the same for important reflux requiring a revision. I believe that if you follow a very strict technique and a very careful technique, making a long and narrow gastric pouch, and without exaggerating with the BP limb, it is very uncommon to have important reflux or to have too much weight loss. When I do a mini gastric bypass, I can reach 200, 250. It's not easy for me to go beyond that point. And I'm not very confident with taking out 1/4 or 1/3 of the entire small bowel, as my friend Miguel Carbajo does. And in any case, when I do a mini gastric, even if I make a BP limb of 250, I always make a check. I have at least 3 meters of common limb beyond that, the point, the anastomosis. So my take-home message is be careful, use an appropriate technique. And if you do that with, of course, a thorough preoperative study of a patient with reflux or whatever, it's not so easy to have all these complications. But later I'll show you the numbers in a few seconds, in a few minutes. Thank you.
Thank you.
Okay. Any of the other participants? Dr. Atul, any comments, questions?
As I said, because the main topic of the discussion and the VB today is weight regain after an MGB. So I primarily wanted to ask the opinion of all the other people, that if actually the patient comes, what is your algorithm of, apart from the anatomical way, is there any way that you would want to do an endoscopy? Because even the presentation of the first case, when an endoscopy was done, I believe that the pouch was very small, number one. And secondly, there was no real documentation of the hiatus hernia pre-existing before an MGB was done. So, okay, then let's, once we proceed, then we probably will be able to guess more that if a patient does come with weight regain, which is the topic today, then what are the options available to us in terms of anatomy, physiology, and documentation?
Okay, maybe when Mario introduces Dr. Rutledge and he talks, we might get into that. Okay, Mario, it's up to you.
Okay, thank you very much, Dr. Fobi. Well, it's my great pleasure and honor to introduce a great friend of mine that is the originator of the mini-gastric bypass. We are friends starting from 10 years ago. We met in the IFSO meeting in Hamburg in Germany, and that was the period that I was starting with the mini-gastric bypass. We met a lot of times. Now we can meet only online, and waiting to meet him once again in person. It's my pleasure to give him the talk of his presentation. Thank you, Dr. Rutledge, please.
Dr. Musella, sir.
Yeah.
You again and all of my friends. I have new research. I have a lot of new findings. And I have been given 10 minutes. As you know, having spoken to me in the past, all of you know, it takes me 10 minutes just to get started.
I can confirm.
There have been some very good questions, and I am going to be strict and cautious about using my time. But I will tell you that on several of the topics that have been brought up, I think, Mario, I know of your tremendous knowledge and background and skill, and Dr. Atul Peters and the other members who are here. I do not have the time to go into it, but I think you'll be excited about some of the new findings. And I would point out a few of those that we are hearing already. In other words, Mario said, rare, throughout Italy, rare incidents of revision of MGB. Yet we know others are reporting high incidents of revision of MGB. High incidence of severe, symptomatic, and documented bioreflux. High incidence of excessive weight loss and even death. Yet we have other surgeons reporting very low incidence. And so this is a paradox. We see this odd group of us even tonight saying kind of opposite things. Now, I don't think I can, in my 10 minutes, explain all of this. But if you have time, I have some good research. Now, I have been asked to talk about one thing, and so I will share and talk about that briefly. But there is an old saying, if you prick me, do I not bleed? So be cautious of asking questions after my little presentation, because I will eat up the rest of the talk. 1 minute, I'll share my screen with you, sir.
Go ahead.
So how good is the MGB? So in 3,000 of my patients recently, I've been able to contact them using Facebook. And again, this sounds embarrassing to talk about it, but in the 1 year that I've been in pandemic in India, I have spent a lot of time talking to the thousands of patients, even 5,000 patients on my various Facebook pages. And I invite you to consider using this as well to assess your performance. And I invite you also to look at my patients, to come and see how my patients, now as many as 20 years post-op, you can talk to Rutledge MGB patients who are 20 years post-op. Recently in that group, we sent out a survey and we got data back on a little over a couple of thousand patients. And one thing we ask is, poor, I lost too little weight. Judge your operation, fair, good, perfect, or poor, I lost too much weight, our question tonight. And this is the data we got back, and this is biased. Obviously, patients who've had terrible results may not be participating on Facebook, so this may be biased. But basically, for our question tonight, our percent total weight loss was around 37%. The range was between 6 and 53, and 1.9% said poor, they felt they lost too much weight. And the good group, that is either perfect or good, was almost 90%. Again, very biased results. Poor did not lose much weight, 1.9%. Poor lost too much weight, 1.6%. So almost 90% said either good, 50%, or perfect. That is, I lost all the weight I hoped for, and 40%. Biased sample, so remember. Now, why does it fail? And why do we have the paradox? And I think Dr. Musella hinted at it because he talked about some of the technical performance issues. And I have videos on this. I have drawings that I'd be happy to show you. But one thing I won't spend too much more time on, but I'd be happy to talk in detail, is the technical performance. Because what we think we see, what I think explains the paradox of good results, bad results, is we see many new MGB surgeons who simply adopted it and with an understanding, with a personal belief that the MGB is nothing more than a Roux-Y with a longer pouch and a single anastomosis, or it's a sleeve with the Billroth tube. The second thing, which I have a lot of research on and no one has mentioned so far, is patient's diet history. And I believe that we're all surgeons here. I don't think you'll care about any of this, but I have a lot of research and some new findings. And if you ever have one of these difficult patients, I would be honored and pleased to talk with them directly, because I think I've found some really exciting new information, but I know you don't want to hear about that tonight, so I'll skip it. So again, I'll tell you that I am blessed because many times surgeons call me, and they don't call me to say, congratulations, I'm doing your surgery, my patients are doing well, and I'd like to send you some money. I have never had that call. But just recently, and this is a sad, now that's not a good way to transition, but just in the past week or two, I had two patients call me, one from a country in the Middle East and one from a country on the other side of the globe, with 2 deaths after MGB. Now, is the MGB dangerous and deadly? Or do you need to learn the details and the technical performance of an operation, even a hernia repair, before you do it? And what I see is many people see an operation and they do it. The Y-Omega trial report that when they started doing the Y-Omega trial, they read my first paper, which has less than a paragraph of how the operation is performed. And Dr. Chevalier, who was part of the team, was never consulted to give advice. And they say that the MGB has 30% gastritis. Yet I would say most of us here are not seeing that kind of complications. They had very high revision rates in the first year, and we don't see that very often. So I think that there is an important issue of performance and technique, which I'd be happy to talk about. And I'm not going to talk about bioreflux. I'm going to talk about weight loss. And I use the word failure. I was educated by Dr. Fobi. He says it's a non-responder, and I like that so much better. But I personally often feel I'm a failure. Quiet, Dr. Musella. So bioreflux is another lecture, and I have some research on that as well I think you'll be interested in. And just to briefly remind you that most of my research that I get now is from talking to other surgeons, and we have some effort on this, which we can talk about. These are where I've been around the world, and these are some of my friends: Australia, Pakistan, Italy, UK, Kazakhstan, Portugal, Italy, and other countries. And I'm very honored to be with you all tonight. So let's do a revision of MGB. And MGB, in this case, is usually a 30 to 50-minute operation. If you're revising an MGB, you're blessed, because usually it's an anticolic operation. There's minimal adhesions, there's the pouch. Because you've made a good long pouch, it's going to be just at the level of the transverse colon. There's the anastomosis, here's the loop of bowel. You dissect that, divide it. There's the gastric pouch. Again, we'll talk about this if you want to. This is the lesser curvature. This is the neo-greater curvature here, and we want the staple line to look like this. And many surgeons I see twist this and do an anterior, all kinds of complications there, which we could talk about. And then we do the gastric jejunostomy. Here's the same thing again, another case. These are both about 10 or 15 years old. Staple, divide, and that's the end. That's an MGB revision. So in the series by Dr. Lee, there was a very low rate of revisions. In my series, let's see, so I had 65 patients out of several thousand, and this was mainly for additional weight loss. So the pre-MGB BMI was around 49, and pre-revision was 35, and post-revision down to 24. 65 revisions, major complications 1.5%, and the number of revisions that I've had over time and my patients of follow-up has now gone down. I rarely see it. So again, I think the benefits of MGB are many, but good exit strategy. We saw an example in the presentation tonight that the MGB can lead to problems, but I'll go ahead and stop there and be happy to answer more questions. I hope I finished in time, but again, to my friends who are listening, I would say I have some new research findings, which I'd love to talk to you about at your convenience if we have extra time tonight. But thank you all for the opportunity to present.
Okay, Mario, it's up to you.
Thank you, Dr. Rutledge. Very interesting as usual, but I have no specific comment to do about that. Well, I have a technical a question I will ask to Robert later when Mohit is going to perform his schedule to perform his live surgery. But just to enforce Robert concepts, I would like to share with you a multi-institutional survey we made in Italy that is going to be published soon, and can you see my screen?
No. Yeah, it's coming. All right, got it.
Okay, great. And it's more than 8,000 mini-gastric bypass with one anastomosis that have been performed in Italy in these last years. And I have collected all cases in which a revision was necessary. So, I will skip very quickly. Okay. On more than 8,000 cases, 8,600 and more cases, we had the need, we made a need to make a conversion or revision or a reversal in a little bit more than 2% of all patients. That is 180 to 182 patients. This means, well, the mini-gastric bypass can generate some complications, some issues, some problems to patients, but in the end, there's a lot of centers involved here. There's 3 university centers, some great regional hospitals, and some private clinics. And there's a lot of surgeons that they are very experienced with the mini-gastric bypass. In the end, it's not only my experience, is an Italian experience. You know, we started in 2011 with the mini-gastric bypass in Italy, and starting from 2014, it is allowed, is officially allowed in the SICO program. So at least is a little bit more than 2% of patients requiring revision for all the reasons you see here. And this is how we revised all those patients, making all necessary changes that, as you can see, the most used revisional technique was the Roux-en-Y gastric bypass. This is the, well, once again, a statistic, and the percentage is very acceptable. And this is when all those patients, according to the follow-up, we asked 2 patients, when they found mean onset time, according to the follow-up, when they found all those complications, hypoglycemia, anastomosis, cyanosis, diarrhea, excessive weight loss. As you can see, well, some of them very late, more than 5 years, have developed a gastrogastric fistula. This is interesting. But as you can see, the most common were weight regain and duodenogastroesophageal reflux. This is interesting. But in any case, later than 40 months or 50 months. So going ahead, this is related to the single patients. As you can see, there is a very important rate of patients that develop the duodenogastroesophageal reflux, and a little less of them develop the weight regain. So this is to say, well, this is to remember when Dr. Fobi came to Italy, came to Naples. And well, I go out from sharing well, this is just to remember you all that finally, if you use a correct technique, it's not very usual to find all these complications. And in a little bit more than 2% of all cases, if you are a skilled MGB or OAGB surgeons, you will need a revisional approach that is mainly based on a Roux-en-Y gastric bypass approach. Well, this is my comments, and well, I have nothing more to add. Once again, I will make I will raise a question to Robert when later we'll see Mohit doing his live surgery. Thank you.
Thank you. Dr. Pompa, any comments about the presentation?
I think it was pretty, you know, it's different to see it in graphics. I think it's very well. It was very well put by Dr. Musella. I would love to see the live surgery and get into technical details about the pouch twisting, which is one of the complications we see so often. So I'm looking forward to that.
Mm-hmm. Dr. Jammu?
This is a good Italian experience. And like Dr. Musella has shown, very low incidence of malnutrition, unlike our Iranian colleague had projected. They had revisions or something he was saying, well, because of malnutrition, people are really scared. But we can learn from this is totally Italian experience. The incidence of malnutrition has really gone down, and it has happened in my series as well. Well, in the beginning, in the year 2009 and 10, when we were beginners, we had some experience of malnutrition because we were not very sure about the limb lengths. Now we have so much data to show when to go beyond 200 centimeters, and or either you would limit yourself to 150 to 200, I'm pretty sure that incidence of malnutrition is very, very low with all these BP lengths.
Okay, so far it has been an interesting discussion. And as usual, I try to put on my professorial hat and look at what has been presented. We had a good case presentation. We had a review of the literature, and then we had the founder and mentor of this procedure talk. And I think for the students and the fellows and the doctors watching, I got one thing clear. Dr. Amir presented a series of 17,000 cases, and 474 of them had needed revision. That is 2.68%. Dr. Rutledge talked about reoperation and revisions for after the MGB. He talks about 2 to 2.3%. And Dr. Musella talked about revisions and talks about slightly above 2%. So what I get out of these three presentations from three different parts of the world is that compared to the gastric bypass, compared to the sleeve, the revision rate after the OMGB is much less than with those other procedures. However, the facts that exist are there are three common complications we see with the MGB. I don't like the word MGB or OAGB because it gets kind of confusing, but I'll talk about that in a minute. But what I have come to realize is there is excessive weight loss and protein malnutrition. There is a certain incidence of GERD, and there is a certain incidence of marginal ulcer. So that's what I get out of this. So we have other procedures that are less effective. As a matter of fact, what was impressive was of the 4 possible needs for revision, that is marginal ulcers, protein malnutrition, GERD, and weight regain. The least incidence was weight regain. So we have a procedure that's very effective, but in a select number of cases, there are complications that we have to worry about. So what we get out of this is we have to learn from this and see what can we do to select patients that don't fall in that 2%. And that's what I get out of this lecture. So with that, we'll move on to see what Dr. Mohit Bhandari has to show us. He's doing a revision on a patient, and he has a fellow that's going to present the case. And Dr. Shashank.
So,
you know, we run a fellowship program. We've trained about 10 fellows already, and Shashank is finishing in about a month. So he's going to present the case for today, and we'll go from there. Thank you.
Welcome to Mohakoa. Today we have a 29-year-old male whose weight is 147 and BMI of 47.5. He's non-vegetarian by diet and has only osteoarthritis and obstructive sleep apnea for the comorbidities. He has undergone under MGB, OAGB in November 2018 when his weight was 213 kg and BMI was 69.8. The native weight he achieved was 135 kg and the lowest BMI achieved was 43.6. The details you can see here easily in the graph. Initially the weight of 213, BMI was 69.8, dropped to 135 and 43.6 BMI, and right now his weight is 147 kg with BMI of 47.5. He has a good blood profile with an albumin of 4.3, HbA1c of 5.24, and negative for all the viral markers including COVID-19. The USC showed grade 1 hepatomegaly. That's a contrast study showing the dilated pouch. That's all. Over to sir. Thank you.
Okay, so good evening, everybody. We are ready with this particular case. As you have heard the history, you can make out from the history that this is more of a case of inadequate weight loss. Now, my plan here would be first to demonstrate the anatomy, take opinion from Professor Rutledge and Mario, Atul, and everybody, Jammu and everybody. But let me first do an endoscopy. You know that we do intraoperative endoscopy at our center for all these patients. So before planning any procedure, my intention would be to see. Now you can see this, there is a lot of bile. So for all the surgeons who feel that there is no bile in the esophagus in MGB, you can see this bile all around. If I can demonstrate that, and this is the Z line there. Can you see the Z line? There is mild esophagitis, but there is bile. Can you see the bile here at the Z line?
Yeah.
That's the
Yes.
bile at the Z line. So first of all, this is very important. And I'm sucking a lot of bile from here. This is actually around 300 to 400 ml of bile, which is there in the fundus. This is a nice tube. So you can see nice fundus here, good Z line, but I don't find, I would say grade 1 esophagitis. I would not go ahead and, say anything else. But when I go beyond this, what I'm finding here is a nice anastomosis here. And my assistant has blocked it. So I won't be able to go beyond it. This is one of the limbs, and that's the other limb. So here. So this is the other limb, and both of them have been blocked. Just give them the inside picture of the laparoscope so that they can see, give the inside in PIP. Can we have the laparoscopic view in the PIP, please? For them to understand as to what I'm doing. Pawan, Himanshu, is anybody listening to me? Okay. Now you can see that I'm here exactly at the anastomosis. And these are the two limbs which I have. We don't have any ulcer or anything here, but I'm just going to mention two important points. The length of this pouch. So you can see that the length of this pouch is, I would say, almost 16 centimeters. Still, you have a lot of bile which is coming here. And despite the length being 16 centimeters, I could demonstrate you that the bile is exactly at the Z line also. So, when we talk about long pouches not having the bile in the esophagus, I think that myth should be dispelled, because I'm doing endoscopies for all my patients intraoperatively, not only for these cases where we do revisions, but for all these patients. And I do OPD endoscopies and find bile in the esophagus in some of my mini-gastric bypass patients. So that is one point I wanted to make. And this pouch is a good amount of length. I said around 12 to 16 centimeters. And that has not prevented bile to come to the esophagus. Now, let's talk about our port position. So you can see I have an optical port, which is 10 mm just above the umbilicus. We have two 12 mm ports, exactly one in the line, in the left anterior axillary line, and one a little above, 2 finger breadths above the optical port, again in the anterior axillary line. The third, the fourth and the fifth port are both in the subcostal area, 2 finger breadths below the right and the left subcostal area, both in the anterior axillary line. So I'm working with in total 5 ports. We have a 3 mm non-scarring liver retractor here. Now, what's the first step? Let's have the laparoscopic view, please. Okay, now what's the first step now? So the first step here would be to dissect all this adhesions from here, and then we can go inside and count the entire bowel length. So that's the first thing I'm going to do. I'm going to count the entire bowel length here. So so you can see this is the anatomy of the mini gastric bypass which has been created. And
Mohit, what is your program to do a banded?
So what do you say? What do you say? What would you say?
My suggestion. Yeah, I would check for the entire pouch, and then probably a wide gastric bypass, banded or non-banded.
Yeah, that's what I'm going to do. I think this patient already had a band, so we're going to replace that band and do a banded gastric bypass, as you said. Absolutely. But first, Mario, I think I should be counting the entire bowel length, because I don't want to, go ahead and have some surprises. So as you can see,
absolutely,
as you can see, give me a grasper. So as you can see here, we have, this is our afferent loop and this is our efferent loop. First, I'm going to count the afferent loop. So let me go backwards towards the biliopancreatic, towards the duodenojejunal junction. So that's the marked thing on my grasper. So that's around 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, and 180. So you can see that I have a BP limb of 180 centimeters, and that's the duodenojejunal junction here. Is that okay?
Yes.
And now what I'm going to do is I'm going to keep all my afferent limb here like that. It goes back here so that I'm not confusing the audience, and I have my anatomy oriented well. So that's my afferent limb. And now I'm going to count the efferent. So let me start to count it from here. So that's going to be 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, 180, 190, 200, 210, 220, 230, 240, 250, 260, 270, 280, 290, 300, 310, 320, 330, 340, 350, 360, 370, 380, 390, 400, 410, and that's the IC junction. So it's around 420. Okay, so that's my strategy at this point of time. I don't think I'm gonna make the limb length any more or less. I'm just gonna divide this here, and then I'm gonna go and divide it here. This patient then can be converted into a banded gastric bypass. So let me first do the division of the limbs here. I'm not gonna change the length of the BP limb or the elementary limb because we have just a 400 centimeters of a common channel which we require. So let me divide this limb here, and let me go above and make the pouch. So what's the best way to do it? You can remove a lot of things in specimen. Now, white 60 for me.
Well, while Mohit is working, I take the occasion, the chance to make a question to Robert, if I can. My question is, when I do a primary MGB and when I prepare the pouch, before doing the anastomosis, I always ask the anesthesiologist to push down the NG tube, the OG tube, the orogastric tube that is usually 36-38 French. When he does this maneuver, I see the anterior face of the gastric pouch turning medially, turning. So is like the gastric pouch is asking me to do the anastomosis on the anterior face of the stomach.
Give me one more.
And I must, confess, I would say that this is interesting to me because I consider pushing down the tube as the food passing through the gastric pouch. So if the gastric tube turn me the gastric pouch medially, is probably the same that it happens when the food goes down. So Very often in primary MGB, not in revisional MGB from sleeve or from other surgeries, I make the anastomosis on the anterior face of the stomach. That in the end, it comes to be a lateral between the lateral part of the anterior face and the lateral part of the jejunal loop. So, well, I would like to listen to your comment about that, because I've heard a lot of times you talking about twisting the pouch. That is, well, probably partly happens, but I don't know. I've never had problems in this way.
Well, I don't think anyone can argue with your results. I think we would distract our other viewers if you and I went off on this. I have a lot of videos and I have a lot of, I have a whole slide presentation on this topic. So maybe it is appropriate for another time, but I like your question and I think I might be able to give you my opinion, and I will show you some pictures and some patients and maybe we will talk.
Yes, yeah, but because a lot of times talking with other MGB friends, as Dr. Kular or others, and they tell me the same. There's not a rule. Sometimes I go on posterior face, sometimes I go anteriorly, but there's not a fixed rule. So I wanted to know your opinion about that.
It would be an honor and a pleasure for us to spend a little bit of time. I have some data on it, and I have some videos, and I have some patient results from patients or surgeons who call me with complications. So I think it's a very good question. I'm not sure it's for us to do it because I think it takes some time, because you've brought up a good question. I think I have a good answer, but it's not a short answer. As you know, most of mine are not short answers.
Sure. Okay.
Dr. Rutledge, I would also want to ask you, you see the case that Mohit is doing, and on Saturday when we were discussing, you said that once you do an MGB, pouch dilatation really doesn't happen because of the low pressure zone there. Do you think, especially to this case, was the pouch loose initially when it was started? Or do you think the pouch dilatation has happened and that is the reason for the inadequate weight loss?
When I watched his endoscopy, I was not impressed with dilation, but I could be wrong.
Okay.
Can I tell you something?
Sure, please.
We have our pouch dilated with mini-gastric bypass. I don't agree that the pouch does not dilate. You can see this. This is a very nicely dilated pouch. Even with banded mini-gastric bypasses, we had some pouch dilatations less than the normal non-banded one. So pouch dilatation is the natural history. You know, if we say that it doesn't happen, can I have a black? If we say it does not happen, yeah, green is okay. There's a green, that's fine. If we say that that does not happen in the history of the weight loss procedure, I think we would be fooling ourselves. As I said, you know, there was a lot of mini-gastric bypass surgeons used to think that bile does not come in the esophagus. And now today you see that that very much comes in the esophagus. So the point I'm trying to make it, most of things what we talk about here, when we actually go and search for them, they look very different than what we thought actually. So I personally would not agree that the pouch does not dilate. In mini-gastric bypasses, whenever we had faced weight regain, the pouch has dilated. And just like this one, it's a massive pouch. So I'm just going to go and do some dissection and try to make a Fobi pouch here so that we give this patient some benefit. I have exhausted my lifeline. My lifeline would have been if, can I have the head up, please? You have to give the head up. It's not possible to do it at this stage. So if I would have had a lifeline, if I would have had around 800 to 10, maybe 1,000 centimeters distally, but that I'm not having, as you can clearly see. So what I'm now left is, my strongest tool here would be just restriction. I'm not left with the, no, there's a vessel there. I'm not left with the tool of malabsorption here. My best possible bet with this patient would be a banded Roux gastric bypass. What do you say, Mario? We have nothing distally. We have just 400. And I'm not going to give this patient more malabsorption.
Yeah, definitely. I agree with you. And my question is, when you were doing the EGDS, I had the feeling, but probably I'm wrong, that the pouch
The
was...
tube, please. The tube. Yep. Yes, please go ahead, Mario.
I had the feeling that maybe I'm wrong, but the pouch was pretty short.
So the pouch is the pouch is 16 to 18 centimeters, Mario. I counted it. I'll count it again for you, although we have resected it, but the pouch is pretty long. I don't make short pouch. We resect a lot of antrum actually. So can you push the tube, please? Push it more. Don't push it more. Push. Okay. So the pouch was 16 to 18 centimeters long. So
it's a good length.
It's a good length. And plus, Mario, this is not the first time I'm doing endoscopies on MGB pouch. I must have done somewhere around 4,000 endoscopies on these mini gastric bypasses, some my patients and some others. And we find bile quite frequently. In fact, if you talk to my fellows, we find bile. I don't know, Manoj can present the data, or maybe can let me know the exact data, but we present this data to Dr. Fobi in every multidisciplinary meeting, that in how many cases of mini gastric bypass do we find bile in the esophagus. So, what I'm trying to say is that we would try and see things, what we would try and see actively, and not just talking about them, because I don't know how many MGB surgeons go post-op. And I don't think there's a problem in having bile in the esophagus. We have bile in the stomach and in the esophagus, even in some normal patients pre-operatively. The point is, if it causes, we don't know what it causes. We don't know whether it causes some changes for us to maybe cause malignancy. I don't know. I mean, I'm not personally scared if I see bile in the esophagus, because I think that is a natural part of the course of this thing. And usually that will pass through after some time. What do you say?
It's very interesting what you've shown us about doing the GDS just preparatively, because we have seen bile in the esophagus, but we didn't see a high grade of esophagitis. And this is a point we have to think about.
So that's what Mario, I'm saying. I can tell you that we have a lot of patients with bile in the esophagus, but very rarely do we have esophagitis there. So, maybe all those studies in the rats where we are trying to say that, oh, bile causes esophagitis, or bile is a carcinogen for the esophagus, maybe it is different for different individuals. So this patient, you don't see esophagitis. I mean, not to the extent that we have to, think about Barrett's or any other problem in future. What do you say?
Yes, that in the end, the indication you correctly did for these patients is to convert him for basically weight regain more than for reflux. So it is correct. In the end, I believe that, well, we have done some study about that. You can have some bile in the stomach, in the gastric pouch, or in the esophagus, but the system of pressures you generate by doing a long and narrow gastric pouch, it allows a continuous flowing of bile downward, and this helps to have not esophagitis or other issues with bile in the stomach or in the esophagus.
Yeah, absolutely. So, when you see bile in the esophagus in MGB, it's like you want to hang the MGB surgeon. No, it's not like that. I mean, that might be a natural. So, what Dr. Fobi taught me, that all of us think about the length of the pouch and all those things. But I think to have bile in the esophagus is the problem of the gastroesophageal valve or the G junction, rather than the valvular disturbance at the lower esophageal sphincter, rather than talking about the length of the pouch. I don't think so that the length of the pouch in any case is going to be a big factor to determine what sort of patients are going to have bile in the esophagus. Having said that, making a pouch as long as possible is good, because the possibility of it coming to the esophagus gets reduced, but nevertheless, it still comes. So
sure. And this is confirmed by the fact that the vast majority of patients presenting with reflux in the post-op are patients who had already some issues in their EG junction, or a small hiatal hernia, or some reflux, or grade B or C reflux. So this is an interesting issue to develop.
Yeah, so we have to understand that I discussed with Professor Fobi, and we were about to start the PH studies, because we thought, and now we have our gastroenterology department having the PH study and manometry being done. So we thought maybe we need to evaluate these patients more on the lines of the defect of the gastroesophageal junction, the defect of different sort of mechanisms which prevent the reflux, rather than talking about the pouch length. So that's what, and then we fixed our algorithm that we're not gonna, so I'm gonna resect all this specimen and take it away. That's not the part of the procedure which I wanted to demonstrate, but I'm gonna do it later, but let me do this first. Let me show you now that this whole specimen is gonna come out. So I'm gonna completely disconnect it from here, fire a stapler, and then gonna disconnect it. But let me do the other part of procedure, which is more important. Let me first do the anastomosis here. So you can see that this was our BP limb. That's the elementary limb. I'm not going to make the mistake. I'm going to count it again towards the DJ flexure, so that I'm pretty sure that I'm not counting the wrong ways. So this is where we are going. We knew that our BP limb was around 180 centimeters. And that's what I'm trying to do. I'm reverse counting it again, just for the purpose of our audience who was there, who are watching me. What I'm trying to do. So this is the transverse colon here, and that's the area of the ligament. Is that okay, Mario, Professor Rutledge? So we are clear. Now I'm counting 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 40, 50, 60, 170, and 180. So that's my BP limb. Okay, I'm going to keep it here in the left subcostal area. Now let me count the elementary limb, but before I do that, let me divide it a little bit, so that I don't have issues with taking this loop up. Now what we are principally going to do is we're going to divide this thing to the extent that we have a good amount of mechanism to prevent the bile reflux. So I think that studies which have shown is 50 centimeters. Although now again you make a pouch of 18 centimeters or 15 centimeters and expect that the bile is not going to come into the esophagus. That has been dispelled today by seeing that video. So now we go by the studies. Let's take 50 centimeters as the pouch length, as the limb length, to prevent the bile reflux. So I'm going to count 80 just to be safe. This is my elementary limb. So that's 10, 20, 30, 40, 50, 60, 70, 80. So that's going to be my my length to prevent the bile reflux. So I'm going to anastomose the BP limb here. And once we do this anastomosis, then we're going to go do a gastrojejunostomy, and then finally remove that specimen completely out. So this is, the logic which I'm trying to apply. I don't know if I'm correct, but what I'm trying to do is what suits our scenario. We cannot afford to have a common channel of less than 350. Actually, here it would be around 350 now, because we again took a similar kind of length of, say, around 50 to 80 centimeters for making that anti-reflux mechanism. So we again compromised on the 400, and now I would say that that's around, say, 350 as a common channel. So that's my worry, and it has always been that we try and reduce this kind of length and then face diarrhea in Indian patients. So here that was my elementary limb. That's my BP limb. I'm going to do the anastomosis from here, and then we're going to close the internal hernia defect, because that's the new defect which we are trying to create. This is just like any other gastric bypass now. The two limb being anastomosed, and then we have the defect here. I'm just, for the interest of the time, because I don't want to just keep on doing the procedure, I'm going to close this defect by using a stapler. So I'm going to just close this as a staple defect. We can do it hand sewn very well. Or
Mohit, when you do a primary MGB, do you routinely count all the bowel length, or
no,
just in revisional
no. As you can see in this particular case, we just do a 180. You can make it out. So I'm not counting the entire bowel length. I'm just doing a 180 and just anastomosing. I don't do it. So
180 regardless from the preoperative BMI of the patients.
Yeah, even if the preoperative BMI is more, nowadays we don't do more than 180 centimeters of length, because that's what we stopped doing that. So that's the reason why I don't count the entire. If any time I go above 200, then maybe we have to count the entire bowel length, or maybe above 250. But this time, since we are doing a 180 as a standard, we don't usually count the entire bowel length. Okay. Also, I think, Mario, it's very difficult to count that. I mean, I made a lot of bowel traumas doing that. I'm not
sure. I agree with you, but well, I tell you what I do normally in primary OAGB, in primary MGB. I use the preoperative BMI as a guide. I mean, if the patient is between 40 and 45, I remain between 180, 200. But if the patient is heavier, I normally lengthen the BP limb, but before doing the anastomosis, I always count I have at least 3 meters of common channel before doing the anastomosis, but because this is a safety length for me to avoid any malnutrition postoperatively. I do not count for primary cases all the entire bowel, because I agree with you, you can generate some tears, some injuries, and this is very dangerous because you cannot realize it immediately. So just counting, I have at least 3 meters below my anastomosis.
Yeah, but I think that most of the surgeons are not counting it in primary cases, but obviously in revisions we have to count the entire length, because
sure.
That's the final answer for the patient at that point of time. As far as this procedure is going, we are just about to complete the closure of this defect. As you can see that these mesenteries are like sort of not equal in length. You know, the one side is bigger than the other, so we have to do a little sort of, I call it as sutured chittling. So we're just doing a sutured chittling here, a little bit of irregular suturing, where we have to first come through the base, and now we get some equal area to oppose to. So this is what we usually do when we do the anastomosis in our revision cases. And as Manoj already mentioned, that our aim here in his revision case, he mentioned that we usually try and create these adhesions so that they reduce a lifetime risk of, although I'm not saying that you cannot have one, but at least we reduce some lifetime risk of having an internal hernia. Now, this is a common channel, as you can see, and this part has to be visualized very nicely when we sort of complete this anastomosis. So that's our technique of closing the internal hernia, and we have been closing this since the time we started doing gastric bypasses. We had some debate as to close the Peterson space in mini gastric bypasses, because we never had such incidents. In some cases, initially we closed, but then we stopped closing Peterson space and mini gastric bypasses. But we are closing the Peterson space and the internal hernia space and all the Roux-en-Y gastric bypass. So as you can see, this I have already accomplished. The defect is nicely closed. We have a good amount of nice common channel there. That's the BP limb, that's the elementary limb, and that's the common channel. Now what we do, we'll resect this specimen later on, but let me do the anastomosis first. So can I have a head up?
Dr. Mohit, I have a question.
Yes, go ahead.
What is your normal length of a bowel when you do a primary gastric bypass, Roux-en-Y?
Okay, so the primary gastric bypass, most of our limb lengths would be around 80 centimeters of a BP limb and around 100 centimeters of an elementary limb. So our primary gastric bypasses are mostly, I would say they're mostly restrictive.
Okay.
Yeah.
I have a question.
Yeah, go ahead. Fire.
At the first presentation of Dr. Manoj, you showed that you convert the previous mini-gastric bypass to one gastric bypass. But on the movie, I see that you didn't dismantle the anastomosis of gastrojejunectomy totally. You
Push the
preserve the intestine, small intestine lumen, but now you are resected the whole anastomosis at the 3 side.
So these are two different ways, Dr. Amir. You can do it both the ways. Whatever you feel is okay for you. Okay. These are two different ways of doing it. You can either, you know, do it the way Manoj demonstrated or what we did in that particular case, or you can actually resect a part of the bowel and remove it. At the end of the day, our basic aim is that we do the anastomosis, which is safe. Number one. Number two, we calculate the common channel is not less than 400 centimeters.
Yes, I got it. But I think that Genser reported 26 revisional OAGB, and he mentioned that we should, for decrease of possible leaks or fistula, we should resect all 3 sides of the anastomosis, as you do in this nice operation.
So Amir, to be honest with you, I have revised a couple of MGBs, and Dr. Fobi was here and told me that he did not like that area quite fired on the anastomosis. But talk to Dr. Rutledge. He taught us this. I mean, I have revised a lot of them by just firing them on the anastomosis, like I did like Manoj demonstrated, and we never had a leak. And let Dr. Rutledge, express his views. In fact, Kular does it. I think Jammu must have done a couple. We have done a lot, both the ways. I mean, fresh anastomosis or just taking down the anastomosis, both the ways. I think both the ways works. If you feel that it is congested and it's not looking good, you can always, come back and sort of suture or re-resect. But at most times, if you are firing well on the anastomosis, it works. Professor Rutledge, I think you have to speak. You taught us this and we did it and we never had a problem.
Thank you. I think the placement of the staple can be below the anastomosis on the bowel, and I see some people actually fire the staple such that there are actually 2 pieces of small bowel, and then they have to re-anastomose the small bowel. Right. Depending on how the anastomosis is sewn, how much scarring there is, but usually what I have found for my patients is if you staple immediately above the old staple line and then examine the staple line, you can reinforce it if you're worried about it, but generally if you staple just above the gastrojejunectomy, that takes care of it. And this operation, if you were to convert it to an MGB with a longer BP limb, it would take, between 20, just a few minutes. So I think that you could, if you have concerns about the placement of the division, then you should be cautious. As you point out, though, it's usually simple, and I think you need to be careful of having an ischemic segment, or if you feel like the bite of the stapler has been inhibited by the previous scar tissue or staple line. But if you take a few moments and manipulate the tissue and manipulate the stapler, I've found it quite easy.
Okay, so this is what our experience is. The way we do MGBs, we never had problems by stapling through the anastomosis or dividing it the way I did. Why I did it here? Because we had to make a small pouch, right? So we just wanted to go above and just get rid of all those scar tissue there down, which now I'll remove it as a specimen. As Dr. Rutledge says, if I would have to just distallize this MGB, I would have gone ahead, just fired on the anastomosis, and that area works pretty well. So we have done both the ways, never had a leak. But again, you should be cautious about the kind of technique, different surgeons doing different techniques, and also about the thickness of your cartridge which you fire. If you have a thickened anastomosis, maybe a black on the anastomosis or a green on the anastomosis have we have tried that, and we have got ahead with that. So I would say it depends upon what sort of tissue anatomy was created, what sort of anastomosis was created in the previous surgery, and then now what you encounter. So Amir, to answer your question, we never had this issue, but as Dr. Rutledge said, the caveat there would be that you have a nice sort of a anastomosis, which is, okay, so now this is the banded Roux-en-Y gastric bypass. I'm left with this specimen here, which I'm going to resect completely out. So before I do that, let me show you the Peterson space closure, because that's something which is very important for most young surgeons watching us. So this is a big Peterson space here, and I'm going to close this space, but I want to demonstrate how I close it. So this is a transverse colon. The trick here is put all this omentum, bury there below this bowel loop, and try and close it after you have done the gastro-J. So now you see this nice big defect there. And then what you can do is you can have if you use an endo stitch, it's fine. If you use other suture, try and put a knot on this suture so that you have one of your hands which is free and can retract the transverse colon towards the liver like I'm doing. And then the problem why surgeons don't close it, because they don't know how to close it. And they don't know how to close it because they don't know how to expose it. So this is the best way to expose it. Keep one of your hands free and ask your assistant to follow your suture. See, one of my hands is just trying to retract this up towards the liver. And what I'm trying to do is close these defect, and it is actually visualized beautifully in front of my eyes. The moment I try to let this transverse colon and omentum fall in front of me, I would never see this defect, and therefore I would never close it and think that it's difficult to close it. So we have almost closed our Peterson space in 100% of gastric bypasses we performed till date, and we never had a hernia from the Peterson space. And I would recommend everybody, even if you're doing a revision, until and unless you find a lot of adhesions here where you close and create micro defects yourself, I think this space needs to be closed completely. So that's the closure. I'm going to do a quick recap before I start to dissect the specimen out. So, okay, that's my surgical knot. Okay, fine. So that's the Peterson space which is being closed. So what I did principally is went above the pouch, divided that 4 to 5 centimeters above the gastro-J, made a pouch, made a Fobi pouch, put a ring in there, and then did the jejunal-jejunostomy here like I did close the internal hernia, did the gastro-J like this, and then I came here and closed the Peterson space. So that's what I did. Now I'm gonna put this ring in place with the help of a non-absorbable silk suture. As you can see, I'm using a minimizer ring these days. That has a slot, and I have put it a size 7.5, adjusted it to a size 7.5. The minimizer ring. Can you retract the liver a little bit for me? Okay, thank you. So this is the slot which the company gives to fix in the ring. And can you go a little closer, please? Okay, thank you. So that's the nice slot which is there, and these are the different slots to fix up the ring. And as you can see, the ring is lying loose over the pouch. I don't have the bougie in. I'll bring in the bougie just to demonstrate you. We can also put in an endoscope, whatever Dr. Fobi or you want me to do. I can do a bougie or I can do an endoscopy, whatever you would want me to do. So that's the part of the surgery. I'm going to resect my specimen now. This is my specimen. It's going to come out. So I'm going to resect it. In the meantime, if there are any questions, I would answer.
Okay. Jammu, any comments, questions?
Mohit, nice presentation. So my question is, did you do gastric bypass because of the bile you found in the fundus or the esophagus?
Okay, nice question. So why gastric bypass? Now, Dr. Jammu, the problem here is as I already said, that we were not having any option here. You could see that my common channel was absolutely small. What do you say? So what else would I have done? There was no option. I had to give this patient a restrictive procedure, and that's what I do. And the second thing is obviously bile. That bile needed some diversion. What do you say? That kind of bile in the esophagus, you would have definitely done some diversion.
Okay, if the case is you have a still long limb length left, would you, and there's
Yeah,
no...
I can, yeah. Then what I could have done is that I would have gone and maybe what you say, we resect the pouch. I would have definitely resected this pouch. This is a large pouch, as you can see. So I would have not kept the pouch. Can you see this is a very dilated pouch? So I would have never kept this pouch in its present avatar. I would have dissected it, resected the pouch, maybe put in a ring there, and then I would have distalized it as you are saying.
Okay.
But here, after seeing that bile in the esophagus, I would have added a brown anastomosis. But now, since we have the bile there, it's better to go ahead and do a gastric bypass. What do you say?
Okay, my second question is, do you do routine banded gastric bypasses as well, and what are the indications for those?
So I do only banded gastric. We don't do a non-banded gastric bypass these days.
Okay. And what about mini gastric bypasses?
No, they are always non-banded. Some of them maybe as a part of our study, which we are doing to compare both mini and both banded and non-banded mini gastric. It's a part of a trial, but no, we never recommend to band a mini gastric bypass. It's only as a part of the study that whether it makes any difference or not. Because we have some data published by Almino, some data published by Carl Miller, and 3 other Australian surgeons who published the data. So we just doing one study, but not routinely.
Mohit, just a question.
Yeah.
Do you believe in brown anastomosis to divert bile? Do you think it is useful?
What do you believe? No, the brown anastomosis?
Yeah.
Well, to be honest with you, any of such case, my preference would be a gastric bypass.
Do agree, absolutely.
I
believe the brown anastomosis is quite useless because the pressure game always brings bile back to the stomach. So
the one reason which you said, and the second reason is we have less experience with that. We have more experience with the conventional ROI. And you know, honestly, Mario, I would tell you that we have these patients visiting from different parts of the world. When there is a complication like this, and when you have a patient with the bile in the esophagus with a mini bypass, I would want to protect a beautiful surgery called as mini gastric bypass by converting this into a ROI. So my concept is totally different. I would want to change this anatomy immediately so that, you know, nobody in future blames this surgery. So that's my, again, it's my personal opinion. It's my personal, you can say bias, or you can say my personal experience at my center. We are more comfortable than the brown anastomosis with the gastric bypass than with the Brown's anastomosis, like you said.
good.
Well, okay, I'm going to make a few comments and then we can see, we need to see whether there are any questions from the audience. One thing Mohit did not show is if you're looking at the dissecting forceps he is using, he has a marker on it, 10 centimeters. Show him the 10 centimeter marking on your.
No, I told them already. I told them.
Okay,
this is a 10. Yeah, that's a 10 on that side as well. Can you show? Oh,
yes.
That's not a. So we have 10 on my. Yeah.
So when he's measuring the bowel, that's what he uses. He tries to stretch it so it's consistent, so that you have an idea why he's coming up with 10, 20, 30. The second thing, which is very obvious, and I said it before, is unfortunately with the one anastomosis gastric bypass, we talk a lot about the lymph length, the biliary lymph length, but what has been found to be very important is the common lymph length. Because I can't see how we can be so worried about the BP lymph length when we have the Scopinaro procedure that had an unmeasurable biliary lymph length. The problem, we've not really studied this. The problem, there's not too much material in the registry as to what is being done. And so surgeons have just picked up what they want to and blamed that for the cause. What we've done here at Mohawk is by doing routine surveillance endoscopy, we're beginning to question the validity of bile in the esophagus and its correlation with esophagitis. But again, that is stuff that we're going to talk about at a later presentation. Because we're seeing a lot of bile in the stomach and seeing bile in the esophagus. The patients are not symptomatic and we don't see esophagitis. So I think, again, this is prejudiced by the first publication that came out back in 2004 or 2007, by Di Maria and his group, who saw bile and therefore just made assumptions that it's going to be carcinogenic. But we're finding that there's not too much correlation between the bile in the esophagus and the symptoms. But again, other people are going to get the data. The second point is what I said before. The incidence of these complications in the one anastomosis gastric bypass is very small. We talk about 2 to 3%. If you look at complications after gastric bypass, we're looking at complications between 10 to 20% stenosis and all those problems. And all those, in all the cases you presented here, I think there was only 1 or 2 cases where I saw somebody talk about stenosis. Whereas with the gastric bypass, we have quite a few cases of stenosis. And then I'm interested that we saw a few cases by Mario. I talk about gastric fistula, which is something we see a lot in the gastric bypass, but we don't see as much of it in the one anastomosis. But the problems that do occur are significant. And I think what we can take out of this is that we have an excellent operation, very low failure rate in terms of non-responders. It has a few patients that will develop protein malnutrition or have excessive weight loss. At this time, we do not have a criteria to select those patients out. And I think keeping our data in the registry, we might be able to find out who are these patients. So with that, we have about 2 more minutes. Dr. Pompa, any comments from you?
I would like to congratulate Dr. Mohit on his very well-performed technique. I think this is he makes it look very easy, the revision, but we can see that there's a lot of additions. So that speaks of experience. And practically when we have the option of the patient with weight regain, and then we have also reflux, we would definitely, with a short common channel, we would definitely have the only option of converting it to a Roux-en-Y. So I think it was a very educational video. And a well-presented cases before this surgery.
Thank you. Dr. Atul Peters, any comments?
So as Dr. Pompa said, this is actually a very nicely done procedure, and Mohit actually makes it look so simple and easy. It seems as if he's doing a primary OAGB with a high BMI. So I must congratulate Mohit. The only thing that I'm not very convinced, honestly, is probably the dilatation of the pouch, which is a very massive dilatation. So probably in some other forum, Mohit can probably show us the primary video if that is available, and if he's done it, that how was the pouch and how much of dilatation has happened over a period of time. So that is my comment.
Dilatation, we are making very large pouch in MGBs. I think we have to make a narrow pouch.
Yeah, I believe so, Mohit.
I don't know. I mean, this is to me.
Well, I think that's one of the variation. We still don't know what is appropriate in terms of pouch. When you talk to Dr. Kula and Dr. Rutledge, they don't think you should make a very restrictive pouch. When you talk to Mario and other surgeons in Europe, they make very restrictive pouches. So we have to come to an agreement somewhere. And I think the advantage of having this live webinars, we get to see the videos and see what pouch sizes are made. Obviously, this pouch was very big. I think initially this pouch was big initially.
Yes, that's what.
And as you know, with Laplace law, if you start with a big pouch, it tends to dilate more than if you start with a narrow pouch.
So what I can say is maybe this surgery done previously was not a technically, you can say, a very strong one. So this patient had inadequate weight loss rather than weight regain. Let's conclude it this way.
Yeah, I would suggest that. Yes.
Yeah, let's conclude it this way, because otherwise, you know, this kind of pouch, Dr. Atul, honestly, we are not expecting miracles out of this pouch. What do you say? We have to.
It's a pretty big pouch. I would say that'd be about the size of my stomach.
Yeah, I'm a lousy surgeon.
No.
That's
a big pouch, though. That's a good sized stomach.
because this guy eats more than me.
Yeah, I believe it. And look at that stomach there. That's a whole half a chicken.
I mean, you know, as Jammu correctly pointed out, if I would have a good common channel there, maybe he's correct. I would have gone ahead, resected the pouch, and then I would have just distalized. And then what Amir made a point that, you know, resecting the complete bowel versus doing anastomosis on the existent firing on the existent anastomosis, we could have solved that point. And I have done, Amir, many of them. And Dr. Rutledge used to say that you can revise an MGB less than the time you can get a haircut. Do you still use that anecdote, Dr. Rutledge?
Every day.
Every day. So that's it, guys. This looks like a nice Ruawai after the huge resection. Thank you very much from Mohawk Theatre. I hope you enjoyed. If you want, I can do an endoscopy, a quick endoscopic check for all of you since we have half a minute. Let me go and do a quick endoscopy to show the internal anatomy, and then we are done.
Okay.
So now we can see that this pouch is of around length of 8 centimeters. I think so. 6 to 8. Again, depends. We're going to calculate the endoscopic length by using an endoscopy. Abhishek is blocking the efferent limb with a stapler. Dr. Dikshit is trying to help me reach into the esophagus. There is some blood which we expect, obviously, because it's from the bougie. And this is the anastomosis. This is the limb, as you can see, and that's the candy cane, a small one. That's the anastomosis, nice round. And from here, if I go back, this pouch is short. It's not that long.
No, this is nice one.
It's okay.
That's great.
Thank you.
Thank you all very much. Thank you all for donating your time to teach. We really appreciate your contribution. And at this time, we're going to do a promo on the next webinar, which is on Monday next week. And it's going to be on the topic of obesity. This is ready, Himanshu?
Yes, sir, I'm playing.
Good. VBU is a 40-week seminar that covers the whole aspect of surgical treatment of obesity. So next week, we'll be starting the new rotation, talk about obesity and its ramification, etiology, psychosocial and medical complications. Go ahead. Dr. Shivram, I see your hand raised.
Yes.